for it on the computer. So hello, welcome to Insight Today. And today we are speaking with Dr. Robert Luby and his wife, Judith Gervais. Judith Gervais is an independent scholar. She's interested in moral epistemology, philosophies of education, and the intersection of religion and medicine. For the past 3 decades, she's worked as a health coach and educator, empowering chronically ill people whose lives were impaired due to their challenging health conditions. Judith has also taught and tutored children in various educational settings. She has her Bachelor's of Arts in Philosophy from Boston College. Welcome, Judith. And Dr. Robert Luby has spent 26 years as a board-certified family physician, serving patients in community health centers, successfully applying the functional medicine model in marginalized communities and under-resourced settings. During the immediate 16 years prior to becoming the director of medical education at the Institute for Functional Medicine, he served as the director of curriculum and faculty training in an academic family medicine residency program. Dr. Luby holds a bachelor's degree in biology from Dartmouth, and he received his MD degree from Columbia University, the College of Physicians and Surgeons. Welcome, Dr. Luby.
Thanks, Paul. Pleasure to be here.
To begin with, we're talking about functional medicine today, and how did your collaboration on medicine and philosophy begin? How did you bring those two things together? Is there a story there? Was it simply a natural outgrowth of shared interests that kind of pulled this together?
It was extremely existential.
Okay.
Bob and I met in Seattle, and I had become ill. There's just chronic illness, not feeling great,
Right.
towards the end of college. And when we met through a mutual friend when he was in his residency program. And at the time I was working the gig economy. I was early to the gig economy, had a couple of jobs and did not have health insurance. And this mutual friend asked him, just, what do you think she might have? These are her symptoms. And it was, he said AIDS or leukemia at the time. AIDS was very big, but I didn't have any, there was no reason to think I had AIDS, however.
Okay. Yeah.
And I didn't, but I did not get any kind of diagnosis. Just things didn't work well. A lot of chronic fatigue. I mean, I guess you could say, looking back, chronic fatigue syndrome, a lot of fibromyalgia, a lot of brain fog, which is very frustrating for someone who is already Lonergan trained somewhat and wanting to maybe pursue a graduate degree. And I guess so, but Bob still managed to fall in love with me. And I would cycle, Paul. Sometimes especially in the summer when the sun was out, if I was eating a certain way, I would be much, I would do better. I had more energy, better focus. So anyway, so we knew each other for a couple of years as friends, and acquaintances towards friendship. And then when we became romantically involved, I did improve quite a bit when I went on an antifungal medication. So we were getting, their pieces were coming together. But it wasn't until our daughter was about 3 and I was around 30 that I received a diagnosis. And this is interesting, I think, because I wonder if my philosophical background fed into this. But anyway, so I received this diagnosis from an endocrinologist, and it was called polyglandular autoimmune syndrome. Basically, my body was attacking itself.
Okay.
And so she herself suffered from type 1 diabetes. She was very well respected. I was there for a few hours doing these different tests. And at the end, she told me what I had, and she gave me a bottle of thyroid medication. And she said, "This is not going to kill you, but you are going to live a very challenging life. It's going to,
Wow.
Yeah.
That's quite some news to get.
Yeah. So, and like I said, I was 30. So I went home, and at first Bob was excited because like I had a medication. I had a diagnosis.
Right.
And then what does Jude go and do? But I said, but there are further, there are relevant questions
Oh, that's where the
that
philosophy comes in.
it came in, Paul. I couldn't resist. I was just like, I'm
Yeah.
not, I just felt it was intuition and training, I would say. I just was like, I feel like if I take this medicine, I'm never going to know why this happened to me. At such a young age, there was no history in my family. Like, what's going on? And is there possibly anything I can do to ameliorate it a little bit? Or anyway, so Bob kind of, crestfallen at first. I thought we were going somewhere. And I said, just give me a few months. I'm going to just, let me see what I can do and investigate things. And I also am a very curious person. And so I started in on that. And it kept, it's continued. And Bob slowly, he was, I would say, open. He had spent time on an Indian reservation. He had spent time in Guatemala, and very interested in their indigenous, herbs and all that kind of thing. So he was definitely primed. But I think he also already he'd seen how I had suffered, and he was hoping there would be a pill for my ill, as they say.
Okay. Right.
Bob, take it over from there.
Unfortunately, Paul, my wife started creating some bumper stickers that said "No medication without explanation," and that's a good little tagline for this whole podcast today, because the explanatory model of functional medicine is really the key.
Right.
My recollection is I remember looking up polyglandular autoimmune syndrome because in medical school it's one of those things they said you'll probably never see a case of this, but as I looked into it, it was just circular logic and circular language. It says polyglandular autoimmune syndrome is basically this set of symptom criteria, and if you have it, this is the treatment that you should get. But it was descriptive, entirely descriptive. And I said, that's just not enough. And I was already early in my career frustrated with the lack of results, lack of good outcomes I was getting. And the irony here, just to shoot way forward, is once I embraced functional medicine and worked full time in it, I created a training course for other doctors to address any autoimmune condition, identified 8 domains of root causes that they need to consider. And let's say 10 patients with the same autoimmune disease will have different amounts of contribution from those 8 domains. So you have to ask about all of them. But the real thing is you ask these further relevant questions to find out which of those 8 domains are contributing to their autoimmune condition. Why is their body attacking itself? And then you apply different sets of interventions based on their own personalized root causes, which gives it a lot of precision. We'll talk about that probably a little more later on. But this is an approach whose elegance, nuance, and aesthetics appeal to me more than the science itself. This is a method, and I'll get into that a little more. But that was the beauty of it. I fell in love with functional medicine after almost falling out of love with Jude during this process, because it was contentious. But there you go.
It's a challenge. It was much more than just an academic question for you. This is the life of your loved one.
It was a very experiential, real, in the concrete that we both had to deal with.
Yeah, I just want to flesh that out a little bit. We didn't fall out of love, but what was stressful, Paul, is he was pretty fresh out of residency. It wasn't, he hadn't been practicing that long, and it was very much in the front of his mind that you do not treat family because you don't have that critical distance.
Right.
But here I was trying to, exploring which modalities, I was very overwhelming, when you enter a new context and you don't have a lot, your footing yet. But I lured him in with particular physiological questions. But one of our jokes now is, I was reading a book, a woman who had a similar condition, and her husband, I think, was a carpenter. And they were working together to ask the further relevant questions and exploring. They were on this journey together. And I was just like, okay, this is just not fair that this carpenter, just because he was so completely, how we say, like naive, he didn't have the bias. And so he was allowed to ask questions, that because
Right.
Bob had this background, where they try to get that objectivity again. There's Lonergan.
Right.
That so you can see where I'm going with that. And so I did call Bob out one day. It's like, okay, this is it. This woman is married to a carpenter and she's getting more support. But slowly, he did answer questions, physiological questions that I was asking him. And then he helped me figure out who to go see and all that kind of thing. So
truth be told, Paul, she called me out more than one time. So.
More than one time. So
anyway.
Your training, I guess, when you said, Jude, that early on the expectation, the thought, the hope was, a medicine for an illness or
pill for an ill.
Pill for an ill. Yeah, pill for an ill. And I imagine, Bob, that was that primarily the training heuristic module that you had come to this with yourself? And in this process, it sounds like you discovered this functional medicine. You were primed because of your own experience in more indigenous communities and natural medicines. Can you talk about that shift from what you call acute medicine and functional medicine? What's the difference there?
Right. The method of evaluating a patient, for example, in Western medicine is very much, its genesis was during a time when acute diseases were very prominent, especially acute infectious diseases. That was a scourge at the time. And it's a model that's very well suited to identifying the agent, let's say, of an infection. It's called the germ theory, a single agent, a single disease. And usually a single treatment. Usually, now it's an antibiotic. So that was the model. The model, unfortunately, didn't change as acute diseases were eradicated and controlled to a large degree by better sanitation measures and public health measures and a lot of that. But when we now have an epidemic of chronic disease, lifestyle-driven disease, behavior-driven disease, they're much more complex with many more root causes. We like to say one disease, multiple root causes now. It's not the old one-to-one correlation. And then any one of those root causes doesn't just represent a root cause of that disease. It can be a root cause of multiple diseases. So this really appealed to me. And that made so much more sense. As I said, it was elegant, and the aesthetics of it really appealed to me. So I knew there was no going back. And after I saw Jude figuring these things out really on her own and applying multiple therapeutic modalities on her own and eschewing the pharmaceutical approach, and she gradually got better, and she continues to get better. I was hooked, and I never looked back, and my career became functional medicine.
So functional medicines, and if we're looking up, if someone is interested in looking up a doctor on functional medicine, sometimes you search for it in a search engine, and some of the results will show integrative medicine or holistic medicine. Are these terms kind of equivalent, or what's the difference among them for those of us who may be searching?
Right, that's a good question. Integrative medicine very quickly refers to you are using multiple modalities therapeutically. So you could use traditional Chinese medicine, you could use acupuncture, you could use herbs, etc. It's a collection of modalities that treats things. Functional medicine will use all of those modalities when it's right for the patient. So therapeutically, there's not as much difference as there is when you evaluate a patient. There isn't a different paradigm for evaluating a patient necessarily, or it's not so different in integrative medicine. With functional medicine, it is very different. Maybe I should show a few slides here, Paul, and explain to people how that evaluation really differs. And what the audience will I think perceive is how it does exemplify how functional medicine does represent a higher viewpoint. If we consider a higher viewpoint, taking a previous understanding and in a richer and broader context. So we don't do away with our conventional training. We just understand it in a richer and broader context. And then it also gets to what I alluded to before about what I learned in Western medicine training is a descriptive approach, and functional medicine is really an explanatory approach. And for my distant reading in philosophy and Lonergan, I know that's a part of getting to a higher viewpoint too, is really having an explanatory model or method as opposed to a descriptive model. So let me just share a few slides and we'll walk through that. So this slide, are you seeing the share okay now?
Yes. Yep.
Okay.
You can see
This
the
slide
Western medicine.
Right. This represents what I learned in medical school. The model was learn the signs and symptoms, and then you make a diagnosis based really on criteria or a checklist, and you map it to an organ that's involved in that diagnosis. And what I would say is this is a symptom and organ-based approach, fairly reductionist, very effective in some acute diseases. But what it does for you, think about, again, about a patient with a chronic complex situation like Jude's. All you've done is identify the symptoms and the effects of the disease. You've made a diagnosis of disease. You've diagnosed what we call the phenotype, what's externally apparent. But all you do is treat the symptoms and the effects. You're so often not getting at the root causes. So what functional medicine does to put this in a broader context, we don't do away with this, but we take this basic question that I was trained to ask. What are the patient's symptoms and diseases and which organs are involved? And this is the question that we now ask in functional medicine. What are the patient's physiological dysfunctions and imbalances? And what are the root causes? So it's diagnosis agnostic or disease agnostic. We can take somebody like Jude who defied diagnosis for years and then say, oh, even though we don't know what a diagnosis is, her symptoms don't fit a checklist criteria, we can understand what her dysfunctions are, and we can address those therapeutically. We can treat those because they would represent her root causes. So if we look back at our tree model, this is the way we evaluate a patient in functional medicine. We think in a systems-based way, which I'll flesh out in just a few slides, root cause medicine as opposed to symptom-based. So we're identifying personalized root causes of the symptoms and effects. Another person with polyglandular autoimmune syndrome would have had different root causes than Jude, but they would have the same symptoms and effects. So that's very important. We have to discern that. Different patients with the same diseases get different treatments. So we diagnose dysfunctions in addition to diseases, and we diagnose not just the phenotype, but the endotype. What's happening inside the patient? What are the processes that are working well and not working well inside the patient? That's endotype for those of you who are not familiar with that term. So what it allows us to do therapeutically is address the personalized root causes with precision. That's why you'll see multiple modalities used with functional medicine and integrative medicine. It's not just a one pill for the ill. It's, oh, well, these are your 8 different dysfunctions that I've identified. We can probably put together a list of 5 different things you can do or stop doing in order to address those 8 dysfunctions. So functional medicine, in terms of that higher viewpoint, in the broader context, gets down to the trunk and the roots of the tree, which I'll show you here in a little more detail, just so you understand what are these root causes. The foundational root causes are lifestyle factors, sleep, exercise, nutrition, addressing your stress, and human connection, relationships is important. Those profoundly affect physiological function, which is what we're after here. Not disease, but physiological dysfunction. One layer up, we know that mental, emotional, and spiritual factors affect your physiological function. So do your experiences, attitudes, and beliefs. Think about adverse childhood events. We know that it doesn't make a child sick right there when they're experiencing abuse or neglect when they're 5 years old, but we know they have a much increased risk of disease when they're 35, 45, 55. And of course, there's genetic predisposition. Some terms specific to functional medicine that are not used in integrative medicine or any other medical model or method are antecedents, triggers, and mediators. These are the further relevant questions we ask of a patient. What are the patient's antecedents, i.e., what happened in their life or even before their life began that predisposed them to physiological dysfunction? Triggers, what events in their life activated physiological dysfunction? I've never been the same since my divorce, since my surgery, since my car accident. Those are triggers. Mediators, what are you currently doing or not doing that prevent physiological function from improving? These are often lifestyle factors and diet, but they can be also negative thought patterns, for example, and emotional states. And then the crown jewel of functional medicine evaluation is what we call our matrix, which is divided into 7 different physiological functions. You see them at the top here. Assimilation is, how do we take things in? How do we digest and absorb, especially nutrients? But it also involves the mental, emotional, spiritual level. How do we take in emotional phenomena?
I can't see the matrix.
Now, we're not there yet.
Oh, sorry.
The top layer here. Defense and repair is the function that protects us from infections and repairs damaged tissue. Energy is really our mitochondria, how they supply the energy we need to generate and utilize all these functions. Biotransformation and elimination is how we get rid of waste products and toxins that we don't need. Communication is the function, how our body communicates from one part of the body to the other with hormones and neurotransmitters and other chemicals. Transport is how we move things around the body. And then structural integrity is the actual structural components of the body themselves, which if they are not in good condition, or if they lack integrity, none of these other processes can work. So those 7 processes are fitted around our matrix. So Jude, here's our matrix. You can see in the white area of the matrix, those 7 functions. And they're positioned that way because everything within the mental, emotional, spiritual state will affect those physiological functions, positively or negative. And then the root causes to the left, those antecedents, triggers, mediators that I spoke of earlier, they affect physiological function, as do the personalized lifestyle factors down at the base of the matrix. Sleep, exercise, nutrition, stress, and relationships. So it's all interconnected. And the elegance and beauty of which I spoke, Paul, is that this is not a reductionist approach. That explanatory approach here takes into account that all of these influence each other. So it's entirely a systems-based approach and a network approach, very complex and much more difficult to learn than what I learned in medical school. But the outcomes with patients are phenomenal. I used to feel like I was helping maybe 10% of my patients. Now with this systems-based approach, I feel like I'm helping 90% of my patients. So this is the tool that I use in my mind to map what's going on with a patient. But when I'm trying to explain to a patient, to help them understand not just the description of their symptoms, but what's causing them, this is how we have the higher viewpoint with our patient. Their life is represented by that arrow there, birth on the left, their current age on the right. So we represent their diseases and diagnoses down in the bottom on the right there. That's the lower viewpoint that I learned in my conventional training. But we explain the patient's antecedents, triggers, and mediators as the root causes of their diseases and diagnoses, and show them how these contributed and actually caused them. And that would explain their high blood pressure, their high cholesterol, their thyroid problem. And the same is true if they just have symptoms but no diagnosis. We can say, okay, even though you have no diagnosis, these are the root causes. These are the physiological dysfunctions that are causing your headache, or your lack of sleep, or your weight gain, or your fatigue. So that's what we do in functional medicine in I hope, a brief nutshell that helps the audience track what we're about to say later on here. So I'll stop my share and get back to the 3 of us. So thanks for letting me share that.
Thank you. I mean, in the one hand, it's very, it's elegant, and I'm sure it'll take a long time to assimilate. There's a lot of information.
It took years. It takes years, but
it takes years.
Yeah.
So
I was gonna say I could comment just as a coach. So when you saw that the timeline or any aspect of it, when they said the modifiable lifestyle factors, that's really mostly what a coach does. Maybe
can
touch
you say
upon
a little bit more about, so this might be a new thing for a lot of people. Certainly it was new for me very recently, this idea of a nutrition coach as a part of your kind of healthcare team now.
Right. Yeah. Exactly. There is healthcare teams are what they are doing. So I actually do not have a degree in nutrition officially. I certainly learned a lot because I utilize that a lot in my journey to getting well. In particular, a very common problem even though Bob said, there are a lot of the root causes vary for each person. It's very individualized, but a common theme is dysbiosis of the gut. And that partly because it occurs often from antibiotic use, or a lot of antibiotics, and poor diet. And that was definitely what happened to me in my early 20s, along with a lot of stress and a lot of mold. I moved to Seattle and lived very cheaply. There was the mold on the mattress stories and things. But anyway, so the gut dysbiosis, that's what happened to me. And that causes a lot of brain fog. And that's a common one for folks. So nutrition was essential. Changing my diet was essential to overcoming that. And so again, where it's very personalized, but there's definitely certain problems that are more common than others.
So you talked about.
Anyway, go ahead.
No, go ahead. You're about to continue.
Oh, okay. So just as a health coach, I didn't have a nutrition degree, but I was very well educated in it. But so yeah, what a coach does is, it's really, as I said in the description, it's really to empower the patient to feel like they can get well, and to let them know that they are essential. Their actions, their thoughts matter. And so often, in the healthcare model, the team model, the doctor will figure out what's going on, but the coach then relieves him or her of the responsibility of working with the patient to try to help them make the changes that will probably be beneficial. And yeah, so they turn it over to the coach. The coach is familiar enough with the medicine to be able to explain why, we're asking you to do X, Y, or Z. So we don't diagnose it all, but we educate. And then it's just to be there for them, help them figure out what can you do, okay? Because sometimes it is very overwhelming, the changes that we're asking for, very overwhelming. Or again, like for me, when it's a lot of these people have been feeling exhausted for a long time. They've tried a lot of things, functional medicine over at least the last 2 decades has often been the 6th thing they've tried. Versus now, I think we're getting the message out and people are finding us earlier. But it's to help sort of create a strategy, and also to support them emotionally, and to educate them intellectually on it. So yeah, it's just having we're often called the cheerleader as well for them.
So like, one thing I'm interested in terms of getting a better handle on the 7 systematic systems aspects, the 7 aspects of the system that Bob was just talking about. Jude, you mentioned 2 things relevant in your own life. One is, this dysbiosis, which if I can map it onto some common sense language to try to move the conversation along. We think about health in terms of an internal and an external environment, right? So you got the internal environment of your own dysbiosis, your gut bacteria, and you had mold in your external environment. Now, I wonder is there a way of mapping that on in some way to the antecedents, mediators, triggers? Are the internal and external elements, are they antecedents? Are they mediators? Are they triggers? Do they work in all 3 ways differently? How can you help me to understand that?
Yeah, and that's actually something else the coach does often. So for me, in my situation, my antecedents, so antecedent, obviously it's anything that's been detrimental to my health since in utero.
With a delayed effect. It does not have an
delayed. They used to talk about way back. They don't use the image anymore, but it used to be filling your barrel, and a lot of times you don't notice until the barrel's full, and then the water or whatever is sloshing out. So for me, as I was saying, so I had a series of antibiotics at the end of college, and then the first couple of years in Seattle. And so that wipes out the good bacteria. And then what I replenished it with was Rebel granola. And when I started eating, my diet did not help replenish the good bacteria. That's what I was trying to say there. And I just ate.
That's a mediator.
Which is a mediator.
That's a mediator, yes. Because it's an ongoing pattern of behavior or an action that's ongoing.
Okay, yeah. Great, thanks.
So for me, we didn't, again, this is over 30 years ago. And so, now I think a lot of folks, I'm not always sure what is out in the, what is common sense at this point. But I think a lot of people do know that whenever you have to take a round of antibiotics, afterwards, a lot of times they take yogurt, or cultured vegetables, whatever it is, to rebuild that inner flora. That's so good.
Let me take a stab.
Okay, we'll let Bob.
We now know that there's genetic differences amongst individuals that make you more or less susceptible to exposure to fungus, mold, etc. That's an antecedent. It doesn't affect you right away, and antecedents don't affect unless a trigger activates them. The trigger that activated Jude's probable genetic predisposition to this was the frequent antibiotic use at a certain time in her life. So within a short time after the antibiotics, as she mentioned, she didn't have good bacteria in her gut anymore. The bad organisms took over, including yeast in her gut, not just externally. So that's the trigger, is those antibiotics. The mediators is what she was eating, because that was feeding the yeast as opposed to feeding the replenishing of better bacteria. We now know that if you eat the right foods, the better bacteria will come back. So that's an example of a mediator in Jude's case. So that's antecedent, trigger, and mediator in her little case vignette.
Yeah.
Okay. Thank you.
Yep. I had mold inside and outside. I was
inside and outside. And the food that you were eating was helping the mold to proliferate, the fungus, as well as, or maybe not helping.
Right. Exactly. I just had no idea at that point. Yeah.
So the role of the coach, as well as cheerleader, sitting in a doctor's office, it's very hard to explain my whole environment. I imagine that the role of a coach might also be to visit the actual environment, or to go through and gather information about a person's dietary habits, about these patterns of behavior that you really can't get you certainly can't get them in the 15-minute interview.
Yeah, exactly.
You may not get them in the office either.
Yeah, if the physician is working alone, then they do the timeline, and they always do the matrix. But if they are a part of a team, then they often do ask the coach to do the timeline. And the coach will do a timeline. Also as a coach, I've worked with people who didn't have a physician. They were or they had a regular doctor. And so I would do the timeline with them, and sometimes you could actually help them create questions for their regular physician. I knew enough to do that. But absolutely, yeah, the timeline of what is their nutrition, what are they eating, and you absolutely can say, do you have mold on the walls? Like on the back of check your mattress for mold, or is there mold in your home? Mold is a huge one. Actually, Bob's sister ended up having mold, even though she lived in a very nice home. It was fine. You wouldn't have suspected it, but it was an issue. So.
Yeah. Well, go on. I'm gonna.
Okay. Well, I was just gonna say. So it is the modifiable lifestyle factors is what we as coaches, they go through the whole thing, everything you can possibly think of about that. And again, sometimes we know some things that are easy, like with sleep, that aren't, as long as they aren't pharmaceutical interventions or anything. It's walking it's a kind of a fine line between, what we can actually, we can't prescribe things, but we can, if we happen to know, like I do, that, late night on the screen disrupts your sleep, things like that, that a lot of the whole it's called biohacking. There's a lot of independent people, who are, who experimenting N of 1 with themselves. They've come up with a lot of good information as well. And so it's a little bit of that as well, trying to help this person figure out what they, I'm thinking more when there hasn't been a physician involved, but trying to help them figure out what they can handle, and so giving them some information.
So the
Well,
area that you're,
let me just return to your question, because there's probably others in the audience who are skeptical that this approach can work. As you mentioned, you can't do this in 15 minutes. I have created a training program for physicians also, how to do functional medicine in 15 minutes. But
This is very new, yeah.
okay.
More time does need to be invested up front, but we've done cost effectiveness studies, and you have maybe more visits, more time up front.
Okay.
And after 9 months, you end up having fewer visits, fewer medications, fewer lab tests, fewer supplements. So 9 months is the typical break point where you start saving costs. And the great example of that is it's really quite easy to reverse diabetes if you have a willing patient and a good coach helping them.
Okay.
So if I take the conventional approach with pharmaceuticals, at the end of a year, somebody with diabetes will have more visits, more tests, more medications.
Oh,
At the end of a year with functional medicine, fewer medications, fewer tests, fewer visits. And that's it. Time invested up front is what it's about.
that sounds great. You mentioned among antecedents, genetic predisposition. And I wonder if you can comment on what we now, when I was in college in the 1980s, genetic predisposition was kind of a thing written in stone. Now, with our understanding of epigenetics and the way in which some of these, the mediators and triggers might actually interact with that, it becomes a lot more fluid, huh? So
Yeah.
It's so great that you brought this up, because many species, such as worms and mice, have more genes than we do. And many species have fewer chromosomes than we do, but more genes, which means there's a lot of what we call junk DNA in our DNA. We didn't know what it was. It doesn't code. They're not genes. They don't code for proteins, which is what a gene does. So all this junk DNA that we used to think was useless is actually the place where other chemicals dock onto the chromosome or the DNA, and they either turn the gene on or off, the expression of that gene on or off. It just so happens that obviously there's genetic differences in those junk DNA, which are probably more important than the genetic differences in the genes themselves. So that gets into your antecedents. And then the triggers and mediators that we're talking about largely are what we call epigenetic, because they affect disease expression. So we know that sleep, if you sleep adequately, you create certain chemicals which do very good things. When they dock on your genes, they create anti-inflammatory molecules, et cetera. If you do not exercise, you will have a certain chemical milieu that causes the expression of certain genes, which are pro-inflammatory. And then there's specific foods whose components will dock onto your genes and turn on the expression of pro-inflammatory genes as well. And by contrast, spices like turmeric, curcumin, they latch onto your genes and turn on the expression of anti-inflammatory proteins. So what you do and what you don't do, what you eat, how you move, how you sleep, and even the one that brought me to tears, Paul, was when I heard the research from a Canadian researcher who measured epigenetic changes, the changes in gene expression, based on whether a person was well connected with other humans or whether they were lonely.
wow.
And even in real time, if you are, in a very short amount of time, within minutes to hours, positive human connection changes your gene expression. That brought me to tears, and but it's been reproduced and established now.
I'd love to get some maybe a reference for that study and perhaps be able to put it in the show notes. It's a beautiful thought. Something that I've been thinking about, which kind of goes back to this, you had mentioned the difference between functional medicine and holistic or integrative medicine, and I thought I heard you say that with respect to the holistic and integrative, sometimes their model is very close to the germ model, the acute model. And what I see when people are marketing natural supplements or marketing specific dietary habits, sometimes they do tie a a vitamin or a food or a product, a food substance, maybe a natural substance, a root or an herb, but they tie it to a symptom. And they often talk about taking these natural supplements as anti-drugs in some ways, using kind of that same sort of model. But we are talking about, with respect to the relationship between turmeric and gene expression, does get at something more explanatory, something more foundational, as you've been pointing to earlier. So it's not turmeric in order to help your headache or your cough or whatever symptom you're experiencing, but it's also different from a pill for an ill.
It's turmeric to upregulate functions that are not functioning well, that will help your own body take care of the cough. That's or the diabetes or the insulin resistance in diabetes.
Okay.
So what you're referring to is known very commonly, Paul, as green pharmacy. It is the replacement of symptoms matching to pharmaceutical medications and symptoms matching to an herb or a supplement. And that lacks personalization and precision just as much as a pharmaceutical approach does. So that's why I said therapeutics can look very much like Western medicine and integrative medicine if that's all you're doing. However, if you're applying the evaluation, the method of evaluation of a patient that I just showed you with antecedents, triggers, and mediators, you will never just pick a botanical or an herb or a supplement off the shelf for a symptom. You'll say, what are the root causes of this patient's symptoms? What makes this patient this patient? And you will select from a variety of modalities. Sometimes it's just you need to sleep better. Sometimes it's just you need to laugh more. Relationships. Sometimes it's you need to change what you're eating. And usually it's a combination of multiple things like that, which is where the coaches become so helpful, because they have the time to invest in identifying what blocks a certain person from being able to make those changes and really helps them make those changes so that their gene expression changes. And you're not just doing green pharmacy.
I see. So wonderful. In my own experience as a counselor, I get some of the same kind of confusion where people will sort of map lifestyle changes onto their understanding of coping skills. And they might think about, I may talk about meditation or may talk about mindfulness exercises or laughing or developing relationships. And immediately they'll think about these things as coping skills that I would do in crisis rather than see them as long-term, more foundational lifestyles.
The data on loneliness is profound. All of the chronic diseases, the killers, cancer, heart disease, et cetera, you name it, all higher prevalence with loneliness as an antecedent and a mediator, quite frankly. And then I would like to say, going back to what Jude said earlier, the pill for the ill model of what I learned originally, I coined a new term, Paul, which is really functional medicine based and relies on coaches. It's called a skill for an ill. Because we consider health is not health. Your health is not fate. It's not destiny. It's about developing skills to, for instance, take care of those bacteria in your gut, to make sure you're doing things that turn on favorable gene expression and shut down unfavorable gene expression. So you're learning a new set of skills. So I call it a skill for an ill, or multiple skills for any ill, is really what I like to say. And Jude and her coaching colleagues are what really help us do that so well.
I want to emphasize, however, the beauty of the physiology of functional medicine as well, because it isn't just the lifestyle factors. So he's kind of talking about my realm, and I'm going to throw it back into Bob's realm, where it's functionally related sets of physiological processes that that they are working with. And so while you can the beauty, I guess, of a lot of these nutraceuticals and diet is it's unless you do something extreme, it's not as dangerous as it is to take to prescribe yourself a pharmaceutical. But it is really helpful to have the context of a complete functional medicine workup. I remember one of the something that ties these two things together is an early insight that Bob had that he shared with me, is that people's livers function differently. And so there's a two-step process to detoxification in your liver. And if you want to know that before you start detoxing. And detoxification is something that almost everybody needs to do if they have a chronic illness. You want to make sure, whether it's mold or heavy metals, whatever you do want to work on that. And so that's crucial. You know, if you really take the nutraceutical, you know, these interventions where you're taking supplements and things, it is really important to know, like, something such as, how does your liver process things?
Right.
You can overwhelm the liver.
Okay.
We talk more
So
about that.
we're going to be wrapping up soon. I have another question that comes out of a paper that you sent to me, and it has to do with so it has to do with lab markers. It has to do with lab tests. It has to do with how is medicine getting better at testing for and assessing this internal milieu and the healthy functioning of the systems?
The short answer is conventional medicine is relying on technology to get ever more precise measurements without increasing accuracy. So let me unpack that. With a laboratory test, there's now, I remember the first generation thyroid test, then the second generation, then the third generation. It became ever more precise in terms of going from being able to measure, I can't remember the units, but, you know, 1/10 of a nanogram per deciliter to 100th to 1,000th of a nanogram per deciliter. But the problem is that thyroid hormone functional?
Mm-hmm.
That's what it's not testing. It's just testing the amount of it, the quantitative a value with more precision, but not measuring the qualitative effect. Now, with functional medicine, there's two aspects in this specific case. We know that there are other hormones and substances in the body that thyroid hormone affects, and we can tell if it's having the effect it should have. We can tell how functional it is by testing some of those other things. But also, the way that the norm is developed is just by taking a population of people, and making a 2 standard deviation definition of this is what's normal. 95% of the test results are normal. And that's not the case, because it's not always 5% of patients who have 5% of people that you're studying have thyroid dysfunction and 95% don't. But that's the definition of the standard reference range. So the reference range itself can have problems. And then the genetic differences of which I've spoken can also mean that the normal and what's optimal for one patient for that thyroid test is different from what would be optimal for a different patient. And so functional medicine takes all of that into account in terms of laboratory testing. It's a fascinating field. And I realized how many times I was led astray by trusting a lab test that appeared to be normal, but functionally the patient was not normal for the variety of reasons I just laid out.
So it requires Go ahead, Jude.
Oh, I was going to say, I think we were having a conversation about this, having this conversation with you. I suggested to Bob, it seems like allopathic medicine and the high-tech breakthroughs that we've had, in a way, though, it still remains descriptive. You know, we need the explanatory context that functional medicine provides. The specialists can learn so much more about, this organ, or we can, with the kinds of, CAT scans and all, you can see if it's already out there now real, they can see the already out there now real better, but it's not necessarily prompting better questions.
Right.
Versus functional medicine, which provides these heuristics that are really helpful.
Let me provide the other example of a diagnostic test. It's not a lab test. You're not measuring a substance in your body, but think about an imaging test. We've gone from X-rays to CAT scans to MRIs to PET scans. So I think you can probably tie this back to Lonergan better than I can, in terms of understanding is not just taking a good look or taking a better look. When we went from X-rays to CAT scans, we took a better look with higher resolution. CAT scans to MRIs, higher resolution, PET scan, and on and on. We continue to get more precision in our resolution when we use imaging tests, but we're not getting more accuracy in terms of what's going on with function and dysfunction in the body. And that's where this more time-consuming approach of asking further relevant questions of events before and during the patient's life that act as antecedents, triggers, and mediators allow for the personalization that the ever higher resolution and precision of current diagnostic testing do not provide.
Yeah. So what we need is a richer, what Lonergan would call upper blade, in order to bring together, right, this lower blade data that's being gathered by these tests and integrate them.
That is how I refer to it to Bob.
Sense.
Exactly.
Jude has been drilling that in. I'm so glad you brought that in because I forgot to. That's it.
That's
Paul,
okay.
you nailed
Oh,
it.
yeah. Yeah.
So in the last maybe, but in a minute or so, one thing I like to ask in all these interviews is how your own understanding of understanding, or how your own use of your mind, how you've learned to use your minds well, how has that impacted your work?
Yeah, I think the Lonergan's I think of the transcendental method. It is a way of life, and I think it impacts all of my common sense living, as well as my theoretical forays. Coming back full circle to my resistance, my strategy when I was very ill, and I was overwhelmed. I definitely think my training, my orientation, knowing the transcendental method, knowing, just pretty consistently, I say to myself, am I asking all the further relevant questions? This is my experience. You get this a lot with folks. They'll say, well, this was my experience. Mm-hmm. Case closed. You're done because you didn't have that exact experience. Maybe we can't understand you or whatever. So yeah, I think it's very much the underpinnings. It's how I move through life, for sure. And actually something else I was thinking about is I think it requires attention. I'm sorry, it requires courage and humility to be attentive. I've really come to feel this recently, the last few years. Just allowing yourself to be attentive to certain things can be disconcerting. And I think as you progress towards responsible action, that need for humility and courage increases. And I certainly don't always, I fail often, but I think, but knowing, having that orientation, that transcendent trajectory of what knowing, what understanding, and what knowing really is, and then what acting responsibly entails. It's my North Pole. I mean, whatever. Sorry.
Right.
Well, I hope this doesn't do a disservice to Lonergan, but be attentive, be reasonable, be responsible. Being attentive, we also train practitioners to attend to themselves before each patient encounter, to make sure that they take everything that they're thinking, clear it out and just focus on that patient. We call that gathering yourself. That's the first step of functional medicine, which I haven't mentioned. And then in terms of being attentive, I've explained how we are attentive to a different set of data as well than just what are your symptoms. Be intelligent implies mapping what the patient tells you about the events in their life to those physiological root cause dysfunctions. Being reasonable means selecting just those interventions that are going to be personalized to that patient's dysfunctions and what were the root causes of their issues. So for me, that's being attentive, being reasonable, being attentive, intelligent, and reasonable in the model as I use it in a clinic setting.
That's beautifully said. I think Lonergan would absolutely agree that the foundation of scholarship is the scholar. The foundation of your practice of medicine is you as a medical practitioner. It's you using your own mind, your own experience, your own love, using it well to the benefit of the patient. That's beautiful.
Yeah.
Well said.
Thank you, Paul.
Well, thank you so much for sitting down with us together, and I wish you well in in your work as physician and coach and educators, community members, and patients.
May
Yeah, and
our
thank you
paths
for the
cross
work on
again.
it. Yes, yes. Good luck with all the insight today. This is exciting.
Right.
Community.
Well, thank you.
Okay, take care,
Thank you,
Paul.
Paul.
You too. Bye-bye.
Bye.